All right, so we're almost there with our full capacity. I do see a couple people are already starting to ask some questions, and that's great. So I'll go ahead and lay some ground rules first, just because we do have a lot of information to cover, and we don't want to hold anybody too long. We want to be as efficient as we can. So I would request that everybody please hold all questions until the end of the seminar. We'll get to a point where I'll open questions to the entirety of the group. When you do that, I would request that you use the Q&A section and not the Zoom webinar chat. I would request that you keep that for conversations between each other, comments, or saying thank you for Pat and Robert for taking the time to join Project Lyme to do this. Very generous of them to do that, I agree. But again, hold all questions until the end. If you do have a question, submit it through the Q&A, which a couple people already have, so thank you for doing that. And I'll run down and ask any questions that cover information that we may not have talked about earlier in the webinar. Also, I want to take this opportunity to again remind you all that Project Lyme is very happy to present this information to everyone for free. We're thankful for everyone who's joined. I am going to put in the chat quickly now, and again at the end of the webinar, our donate. Please, if you have $5 to $10 and you feel you really benefited from this webinar, feel free to donate so we can continue to provide high-level education that you'll receive over the next about hour or so throughout the rest of 2021. So thanks again, everybody, for joining, and I would say we can go ahead and get started. So I will first introduce Dr. Robert Bransfield. Many of you may know him. He currently hosts our Lyme and COVID Facebook group. He's been very involved in Lyme disease throughout the entirety of his career. He has been an associate clinical professor at Rutgers, the School of Medicine, and he currently owns a private practice of psychiatry in New Jersey. He's been the past president of the New Jersey Psychiatric Association, as well as the past president of International Lyme and Associated Diseases Society, aka ILADS, and one of its educational foundations, which is ILAD EF. And he's currently a member of Lyme Disease Association Scientific and Professional Advisory Board. And that leads me to also introduce Pat Smith. Obviously, Robert and Pat have a good relationship. She is the president of Lyme Disease Association Incorporated, and she's also a member of the Columbia University Lyme and Tick-Borne Diseases Research Center Advisory Committee. In 2020, being this year, of course, she's completed 2 terms as a member of the Health and Human Services Tick-Borne Disease Working Group, as well as being a 4-year member of the Department of Defense Congressionally Directed Medical Research Programmatic Panel. And she is the former chair of the Governor Lyme's Disease Advisory Council in New Jersey, and has testified twice before congressional committees on Lyme disease and other tick-borne illnesses. So obviously, as you guys can see, both of these two are extremely qualified to be speaking on the IDSA guidelines. So I'll go ahead and open the conversation up right now, and I'll start with Pat by asking, who is IDSA, for anyone who doesn't know?
Well, the IDSA is the Infectious Diseases Society of America, and it's a very powerful medical specialty society of over 12,000 members, physicians, scientists, and public health experts who specialize in infectious disease. And members are considered by the federal government agencies to be the experts in Lyme and tick-borne diseases.
So what? Yeah. So what is?
I'd like to make a comment there about what an expert is. Okay. No, who's the expert? Are they bureaucrats? Are they researchers, administrators, public health officials, or are they the doctors who see Lyme patients every single day in their office, year after year, decade after decade, and have the long-term responsibility of caring for these patients, versus the people that may see them once and say, the test is negative, you don't have Lyme disease?
Yeah, that's a great hypothetical question that I think everybody on this call already knows the answer to. And I'm sure as we roll through the rest of this information, we'll be able to identify exactly what you're just talking about. So Pat, I'll come back to you here and say, what is IDSA's relationship with Centers for Disease Control?
Well, the CDC has always posted the IDSA guidelines on its website until about a year ago. And at that time, they asked 3 advocates to be on a call with them. They wanted to show CDC's new Lyme guidelines page, which they said does not have the IDSA guidelines on it. Well, I was on that call, and I pointed out that on that page, what CDC had done was they had taken the Lyme treatment regimens out of the IDSA guidelines and posted them there, along with references that CDC claimed supported those treatment regimens. In actuality, their page actually showed the IDSA protocols for Lyme. So I told them this, and their response was, nowhere does it mention IDSA Lyme guidelines here on our page. So I thought that was a rather interesting little trick, if you will, to take that out of there and then not call it the IDSA guidelines. However, CDC did place references to other, quote, forms of Lyme disease there, neurologic, cardiac, arthritis, with a note that they may require a longer treatment course. And by the way, that's also noted in the IDSA guidelines. CDC also included a statement that in a small percent of Lyme patients, their words, symptoms continue after treatment, and they reference post-treatment Lyme disease syndrome or chronic Lyme. And that was something that we on the phone had said that they needed to have some kind of reference to the fact that people are still symptomatic. I knew they would not put too much up there, but at least they did put that part. But you can see the kind of relationship that they have with IDSA.
So Bob, I'll then swing this over to you and say, as somebody who sees patients day in and day out, what do you feel about that relationship between IDSA and CDC?
Well, the CDC also, does anybody in CDC actually treat Lyme disease? And can you really be good at making an assessment of patients when you don't see patients? So CDC is public health officials. They're researchers. They're bench scientists. They're not on the front lines. So I think they're, as a group, even more removed than many of the IDSA academician or administrator people that try to establish these guidelines. So it's to be effective, you need a better connection to patients, and that's a concern that I have. And even though you see these organizations that a lot of there can be large, but the people actually write these guidelines are a very small percent.
Yeah, that makes complete sense. So Pat, I'll swing this back to you. And obviously we know who IDSA is now and the relationship with the CDC, but the guidelines themselves, what exactly are they?
Well, the 2020 guidelines for the prevention, diagnosis, and treatment of Lyme disease have 3 sponsoring organizations. The IDSA, which does say they have 12,000 members, the American Academy of Neurology, which has 36,000 members, and the American College of Rheumatology, which has 7,700 approximate members. And a press release announced the guidelines on November 30th. And they have 33 listed co-authors, 2 from Canada, 1 from Slovenia, and 30 from the US. And their guidelines contain 43 recommendations for clinicians treating patients with Lyme. And they have a 36-member guidelines panel, including 3 patient reps. But unfortunately, they are keeping the identity of those patient reps secret. So we in the Lyme community feel these reps cannot be construed to be meaningful patient representatives. They're not part of a transparent process. Their identities and ties are unknown, and they have no accountability to any patient constituency. So to say that you have patient reps when you have restrictions and you're not allowing the public to know, well, I'm sorry, that doesn't go over too well.
Yeah, and I know Bob feels the same way. So Bob, would you like to elaborate a little bit on those patient reps?
You know, it's, you don't know that it sounds like they're token reps because that's what you had to do to go with grade. But if their names are concealed, how much can they be advocates for Lyme disease? How could an advocate want to hide who they are? I have trouble understanding that. And when you look at the numbers of the number of doctors in these medical societies, on the one hand, it sounds impressive, but the actual number of people in these committees are probably 1/10 of 1% of the membership. And we see the same names again and again who influence the belief system as it pertains to Lyme disease.
Yeah, and if I could just add to that, we don't have any idea who they're calling a patient, you know, and really what kinds of ties do they have? And that is very significant because none of that is transparent.
Yeah,
I would think if someone were in the LDA or one of the big organizations, they'd be broadcasting that they're a member and stating it clearly to everyone, and I don't hear anyone saying that.
Right.
now there wouldn't be any restrictions from them stating that they were a member.
You mean restrictions in what way? Restrictions in the guidelines process?
Yeah, from preventing an advocate for being involved with the community.
No, no. I mean, an advocate, oh, I thought you meant restrictions on them giving their names. No.
Right.
When actually the first ILADS guidelines, I was actually a patient advocate rep on those guidelines, and it was clearly labeled that I was there.
It
Right.
seems no one else's name is concealed in the guidelines process.
Yeah, it would make sense that the advocate is one of the most well publicized people so that you can get involved and actually have conversations and influence it in the direction of the patients. But let's move on to the guidelines themselves. I know that you guys referenced previously that the guidelines had been published in 2006. So when were the last, I just gave that away, but when were the last guidelines published? And since then, what has changed?
Okay, well, basically what happened is those guidelines in 2006 were accepted and posted by the federal government's National Guideline Clearinghouse. And those guidelines, all guidelines that were accepted and published, because they had to meet a certain standard, were considered stale or outdated. That means after 5 years. However, the IDSA guidelines were allowed to remain on that government site until 2016. So that was kind of problematic. And I don't think anybody was appreciative of them being allowed to remain there that length of time. And I would add, by the way, that the ILADS guidelines were up there. In fact, they were up there when the clearinghouse closed down.
And when did the clearinghouse close down?
2018.
Got it. So Bob, I'll swing this over to you because you're somebody who uses these guidelines or is required to day in and day out. So since 2006, what exactly has changed?
Well, I'm not required to use the guidelines. Guidelines are just something that may help us with decision-making processes. So one major change I saw was that they used the grade system, which is a guideline, and ILADS had done that previously a number of years before. They were the first grade Lyme disease guidelines. One interesting thing about the guidelines is post-treatment Lyme disease is never mentioned in these guidelines. And also I noticed there's a section on psychiatry and child psychiatry, which I thought that's wonderful. Finally, they're addressing the psych issues, but the problem is when we get into the details of what they mentioned, and we'll get to that later.
So for those of you who don't know, grade is grading of recommendations, assessment, development, and evaluations. So exactly how does grade relate to these guidelines?
Well, grade is how we're doing guidelines now. And that way guidelines are more uniform in nature, and ILADS claims they complied with the grade criteria. So it's those familiar with the process, that you say the strength and weakness of different recommendations and evidence. So if the evidence is strong, you can give a stronger recommendation. If it's weak, you give a weak recommendation or no recommendation. So it's a way to systematically review a body of evidence on a specific clinical question. And 100+ organizations throughout the world have agreed to use grade as a way of writing guidelines. And many, many people write guidelines. So grade examines evidence in terms of bias issues, imprecision, inconsistencies between studies, indirectness, and publication bias. Now, the ILADS and also the NICE guidelines from England use this, and they found the quality of evidence related to Lyme disease to be quite low. And I think that's correct. Next, ILADS did a risk-benefit analysis and considered patient values. And given the low evidence and the low quality, the risk-benefit assessment allowed options, and that led more options. When you have very, very strong evidence, you would have stronger recommendations. Now, the IDSA included adverse events as outcomes of interest. And because, in their opinion, the evidence on adverse events was of high quality, which that's their opinion, they raised this overall evidence quality to moderate. And that allowed for stronger recommendations, not options. So anything medicine is a risk-benefit decision. And you're looking at the risk of treatment versus the risk of the disease. You're balancing those two. So if you see treatments as being very high risk, you're more reluctant to use those treatments. But if the disease is very risky, then you might be more prone to treat. It's weighing those two things against each other.
Could I comment also on the overall idea of the changes and what's been done and how they've added grade? And they have all these authors on this guidelines. They have all these panel members. They've made a massive amount of recommendations and citations, yet nothing has been changed to help the patients. And I think that, as I was reading through, was one of the most disturbing things to me.
That's a good point, because when I look at guidelines, if it's a subject I know little about or much about, I'd be interested in what can these people tell me that can help me to help my patients. And I found more comments about what I should not do than what I can do that might help my patients.
That makes sense. So from the clinical side, when you're looking at these guidelines, what do you see that's included and what do you feel that is excluded? Well,
when you look at it, it's so voluminous, you think, well, there must be something here of significance. So the guidelines themselves are 48 pages. And if you could break it into 3 parts. The first 6 pages summarize the recommendations, and they summarize recommendations in each category. We can go through those categories. Then the rest of those 48 pages, the final 42 pages, are going in somewhat greater detail about those recommendations. Then there's also a supplement that's 241 pages. And that looks at some of the research that's used to make their opinions. And the 241-page supplement you have to find on their article. You click that and open it up as a PDF document. And when I look at it, it's really very similar to the proposed guidelines. I saw very little difference. So the logic was that they give, and it goes with grade, you do propose guidelines, you send it out to the public, you look for feedback, and then you take that feedback and you may tweak it, but I don't see where the feedback made difference, unless there's something I missed. So the publishing separate guidelines for, they publish separate guidelines for other tick-borne disease. So rather than addressing all tick-borne disease, they really just addressed Lyme. They did mention briefly anaplasma and babesia. They also mentioned Master's disease, which they call STARI, and but there were no recommendations regarding Master's disease. And much of the scientific evidence regarding tick-borne disease is not included. Like an example of, you could say that literature was cherry-picked. I paid particularly attention to the psychiatry part, and there's over 400 peer-reviewed articles on Lyme and psychiatric symptoms, and only 4 were used out of those, so it's 1% really. And this is very careful with the wording. They state they only use controlled trials, and I had a trial looking at the association between Lyme and tick-borne disease, and it was a controlled trial with 3 control groups, but that was not included. And well-controlled articles showing an association with Lyme and psychiatric illness were also, other articles were not included. And then one article, for instance, was out of Eastern Europe, and it showed people in psychiatric hospitals had a much higher positive reactivity for Lyme disease than people in the general community. But they excluded that as not being relevant because it just addressed psychiatric illness instead of specific psychiatric illness. So that was their grounds for exclusion. Now, if we look at the document and kind of summarize it some, you could see with the articles that they cited, they used surveillance criteria as diagnostic criteria. And right there, that showed a weakness. And they also use the phrase non-specific symptoms. And this is something that's, very few symptoms are specific for a given disease. For instance, chest pain and heart attack. You're not looking at a specific symptom, you're looking at a specific pattern of symptoms. So saying that there's not specific symptoms such as like fever or fatigue, therefore things that were considered non-specific such as fatigue or pain can be excluded, and we don't have to pay attention to that. And retreatment, in their opinion, is not supported by any research. They did not discuss post-treatment, long-term consequences, chronic Lyme, persistent symptoms, late-stage Lyme, whatever we want to call it. And it's hard to think of short-term immediate recommendations when you don't pay attention to the long-term outcome when you fail to treat. Shared medical decision was lacking. Now, this is a big part of evidence-based medicine. Evidence-based medicine has 3 parts. The best evidence available, it's never perfect evidence, best evidence available, clinical judgment, and patient preference. And this was skewed more towards evidence, or what maybe cherry-picked, best way to put it is cherry-picked evidence, without clinical judgment, without patient preference. They viewed side effects of treatment as very critical, rather than the benefits. And again, it goes back to that equation, so that it's how bad is the risk of treatment, what could go wrong versus the risk of not treating. And a part of grade that's required is to reconcile other documents, other Lyme disease guidelines. For instance, the IDSA guidelines, which were not by this criteria, the grade criteria, were not reconciled. There should have been a reference to that. They did not look at the Lyme Borreliosis Society in Germany, their guidelines. They did not reconcile with the NICE guidelines. There was none of that, which was required by grade. They failed to adequately recognize co-infections or interactive co-infections to any extent. They disregarded animal studies, but they didn't really disregard animal studies when you look at length of attachment, where then they cited animal studies. So they cited animal studies when it supported a position that they had previously held, but They didn't cite animal studies when it supported a position contrary to the pre-existing opinion that they had. And there was some inappropriate reliance on European trials, and because there is a different strain in Europe, and you can't, although there's some comparison, you have to have limitations of how you can compare it. And there's different strains, for instance, Afzeli or Guarini rather than Burgdorferi. And if we so that's basically an overall thing. Now, if we review the guidelines in more detail, it's broken down into these sections, Roman numeral sections. And I'll comment on a few of these sections. The first section is that I want to comment on is number 3, prophylaxis. So this wording, when I read it, it did me a double take, but I have to, it's confusing. So they say if an antibiotics given only to adults and children within 72 hours of removal of an identified high-risk tick bite, and if the tick has been attached for over 36 hours, identified as an Oxodes species tick, and it's from a highly endemic area. So all those criteria need to be met in order to treat prophylactically. Now, then in section 4, they spoke about a single dose of doxycycline if there's a high-risk tick bite. And that's based on an article that many of us have heard and is highly flawed. In section 6, the preferred antibiotic, so now if, let's say, someone meets a criteria for treatment, is 10 days of doxycycline or 14 days of ceftin or amoxicillin. And the preferred testing for noroborreliosis is what's called paired serotesting. Now, this is the section where you're looking at neurological Lyme. And this is the idea that is Lyme in the central nervous system or not? And their position is that you have to have more antibody reactivity in spinal fluid than in blood, in serum, in order to say that it's impacting the brain and have neuroborreliosis. And I don't quite understand that. Why does it have to be more rather than it could be less? But that was the position they took. And they also took the position of don't test for Lyme in the workup for neurological conditions such as ALS, MS, Parkinson's, seizures, cognitive impairments, white matter hyperintensities, findings on an MRI. And they go back to this point of don't test for it, rather than saying don't assess for it. And to do a proper thing as evaluation medicine, you don't just test, you assess. And testing is only part of your assessment. Then they recommended against testing for Lyme in psychiatric illnesses. And if you think of this wording that they said, and you have to think of this very carefully. There is no controlled prospective evidence for treatment for Lyme disease that is effective for any specific psychiatric illness. Now, there never will be a prospective study because that means you'd have to give someone Lyme and not treat it. That's like a Tuskegee experiment, which is unethical. So there will never be a prospective study that would prove this point. So not only do they say you need a prospective study, but you also need it for a specific psychiatric illness, such as depression or panic disorder. And now in reality, my study that I did and others have shown retrospective studies that specific psychiatric illness incidence increases after Lyme disease. But no one would ever do a prospective study. That's impossible to do. So therefore, based on that, you can never prove the connection based on that, the criteria that they're requesting. And then with children, they recommend against testing with children with psychiatric illness, behavioral disorders, and developmental disorders. Another section is stating that patients with persistent nonspecific symptoms such as fatigue, pain, cognitive impairments who lack objective evidence should not be retreated after what they call standard antibiotic treatment. And what they call standard is their recommended. It's to say it's standard is elevating it to a level that it doesn't deserve. Now, when you look at studies of Lyme disease, the worst symptoms that people complain about as being most disabling are fatigue, pain, cognitive impairments. Now, they call those nonspecific and subjective, when in reality, they are objective if you know how to assess them. We know how to assess them. We can make all those symptoms objective, but somehow they put them in this category they don't belong at as only subjective. And there are ways that you can objectively, so brain imaging for fatigue, all these things. So they're not objective. And non-specific is the other word. So it's not specific symptoms, like a bullseye rash is specific, but very few symptoms like chest pain is not specific for a heart attack, but it's a specific pattern. So fatigue, along with the other complex of symptoms, it's pattern recognition. That's how you diagnose anything in medicine. So their reasoning here, when you exclude the most critical symptoms of late-stage Lyme disease, and when you look at excluding psychiatry and what they call non-specific, or what they label as subjective, which is really something they're not trained to make objective, then you've excluded all the most significant later stage manifestations of Lyme disease.
So I was going to open it right back up to you and say, from the patient advocate perspective, what do you feel is excluded?
Well, I actually, if I could go for a minute back to, I'd like to go back to something on the included and excluded that Bob said earlier, and that was the fact that they state that they only include controlled trials. Yet I'm out there in the Lyme world, and I'm out there at a lot of government meetings, etc., and I have yet to hear them advocate for more trials through the NIH for patients who need the most help, for our chronic Lyme patients. They're not advocating for more trials. Quite the opposite, in my opinion, and a lot of other people. So this does not make sense to me, what they have put in here. Plus, when I look at, excuse me, the fact of something like ALS, and I think ALS has a couple of medications that might extend people's lives or their quality of life for several months. To my knowledge, there is no treatment for that to get them better, if you will, and have them live a life. And so I don't understand their rationale. Why would they not want to have these patients worked up to see if they have Lyme? And the only reason it is because they have this dogma that says that kind of Lyme disease that produces those kinds of serious manifestations doesn't exist. And it doesn't exist because they don't want it to exist. And they do everything in their power, from what I've seen, to prevent it from existing, if you will, in different ways, by excluding all of these things that they have excluded. And it's a travesty.
Thank you. So, Bob, I'll swing this one back to you and focus on the difference between guidelines and then actual standards of care.
Well, we don't want to confuse those two issues. Guidelines, by definition, are something that could help clinicians in decision-making processes and help to guide them in their individualized care of that patient. So they are there to assist. They're not a standard of care. If you look at what standard of care is, and this comes up a lot, let's say in legal issues, the standard of care is established by the physicians or the clinicians who actually treat a condition. And although many things can go into the standard of care, that's the most critical and the most common definition of what constitutes a standard of care. So, for example, whether we're talking about Lyme disease or depression or arthritis, how do physicians normally treat that? Now, the standard of care can have a range, and it can't be rigidly identified because in a restricted way, because if you did, you would prevent further progression and advancement of medicine. And that's a statute, for instance, that is recognized in Pennsylvania. So it's standard of care and guidelines are not the same. And there are many guidelines, often for any condition, and they can conflict with each other. There's, for instance, guidelines, multiple guidelines that may address Lyme disease from one facet or another.
Yeah, for example, ILADs, I know we talked about them a little bit earlier, and I'm sure everybody on this call knows them as a patient-focused organization, and they produce their own set of guidelines. But how do IDSA guidelines and ILADS guidelines compare or differ from each other?
Well, ILADS, it's an international multidisciplinary medical society. And I think actually, if you look at the treatment of Lyme patients, more Lyme patients are treated following the ILADS than the IDSA guidelines. And it's not just ILADS doctors, but other people that may follow the guidelines. So ILADS recognizes more that when you make a diagnosis, it's a total clinical diagnosis. Now, in all of medicine, it's a clinical diagnosis. You don't just look at lab, you don't just look at history, you don't just look at any one piece of it, you look at everything. And ILADS recognizes that in their guidelines, and they also recognize the role of clinical judgment. And going back to those three parts of evidence-based medicine, it's the best evidence available, not absolute evidence. There's never absolute evidence. It's clinical judgment and patient preference. So clinical judgment, patient preference, that's 2/3 of evidence-based medicine. And whereas the IDSA guidelines don't emphasize clinical judgment, and there's more of a rigidity and a restrictiveness in terms of what they recommend in their guidelines. And so the current ILADS guidelines, and they had one prior, which Pat was a member of, and then the 2014 guidelines, which is an evidence-based assessment and guideline recommendation Lyme disease, the clinical management of known tick bite, erythema, migraine rash, and persistent disease. And they use, as I said, they were the first to use the grade assessment. And these guidelines go clinical judgment, clinical signs and symptoms with lab tests that can be supportive. They recognize long-term treatment may be appropriate, but it has to be individualized. Everything's individualized. When you look at studies, they're always done in groups, and you never treat a group of patients. You treat an individual patient. So you always have to individualize treatment. And ILADS guidelines recognize that, whereas IDSA, although they recognize it somewhat in their disclaimer, it doesn't appear to be throughout the document. And they recognize in ILADS persistent infection may be present, and recognize that retreatment with emphasis on shared medical decision-making and patient education regarding the type of late-stage presentation and severity illness is a consideration. There's patient-oriented outcomes with ILADS, clinical judgment emphasis, shared medical decision. You're working as a team with the patient. You're not a dictator telling them what they should or should not do. You're listening to them and individualizing a treatment plan for that patient. And recognizing different patients have different values and ways of looking at things, and you have to have proper informed consent in terms of what options are, and full disclosure, and also recognizing what opposing views may exist. Now, the IDSA guidelines, on the other hand, are more disease-oriented, so not so much patient-oriented. And there's a certain definition of that where we're treating a disease. Once you're categorized as having a disease, then we go by the criteria for treating that disease, and that's basically based on the surveillance laboratory criteria, with the only exception mostly being like the EM rash. So basically that means that if there's a negative lab test, then forget the rest of your clinical assessment. And so we have, I think in general medicine, you have to look at your overall clinical assessment, your assessment, the signs, symptoms, history, not just laboratory work. And so the EM rash alone may make the diagnosis, and then the two-tier testing, although we know the problems with two-tier testing. And it emphasizes short-term treatment and no persistent infection. That's not addressed even in the guidelines. And so there's a belief that Lyme does not persist, even though there's a large body of evidence in the peer-reviewed literature supporting that. And retreatment only for Lyme arthritis, twice maybe, or once for certain other presentations, but it's quite limited. And for instance, the disease-oriented outcome, that's quoted by Ebel. So that's a way of looking at disease. You just treat a disease, not a patient so much. That's an emphasis. Clinical judgment has limited emphasis throughout the guidelines. Shared medical decision is limited or precluded in order to get more of this uniform approach for a disease-oriented diagnosis. And there's no recognition of the ILADS guidelines to recommend, to reconcile opposing guidelines, and no disclosure to say, well, there are other guidelines that disagree with that. And retreatment is basically discouraged except for Lyme arthritis.
I'd like to say something from the patient perspective. Comparing the two guidelines, I don't think that there's any contest. In my many decades of work with patients, I have found that they diligently seek out physicians who use the ILADS guidelines. As soon as they find out, or if they don't know about them, they are seeking them online, trying to find out what else does someone have something to offer me, the patient who's really sick. And I hear doctors telling me that they're overwhelmed with patients trying to get care from them. Their phones are ringing off the hook with patients seeking to get back their lives. And these are the chronic patients. These are the ones that are so sick, and the IDSA guidelines completely ignore them. It's just absolutely unbelievable. And these are the ones that are hard to treat. They might take on the patients early on that they can give what they feel is adequate treatment to, but they don't take on the really sick patients. They don't even acknowledge them. And so the doctors who are treating, and who include the internists, family practitioners, pediatricians, they've given these neglected patients back their quality of life, the ability to go back to work, the ability to go back to school. And we've had a doctor referral system on our website for decades, and it's been used by tens of thousands of patients seeking out someone who will help them. Sick people need help, and they're not getting it from the IDSA guidelines, and nothing has changed from the 2006 in that regard.
Well, you just served up our next section perfectly, Pat. Is obviously the IDSA guidelines really impact the majority of the community, whether already diagnosed with Lyme disease or those in the future who may be diagnosed with Lyme disease. So for those who may not know, who uses and support these guidelines?
Well, the ones who use, so to speak, the IDSA guidelines to diagnose and treat Most infectious disease physicians, many neurologists and rheumatologists, and a large segment of primary care doctors. Now, who supports these guidelines? Public health officials and government agencies, including the military, by and large, support the IDSA guidelines. Epidemiologists support the guidelines, and unfortunately, medical boards often support them also in the job that they have to do. So, and of course, we all know who uses these guidelines to determine reimbursement, and that is the insurers. Now, the IDSA says their guidelines provide recommendations which include those for primary care, infectious disease specialists, emergency physicians, internists, pediatricians, family physicians, neurologists, rheumatologists, cardiologists, and dermatologists. That's their audience of these guidelines.
I'd like to add that when I was more fresh out of training, I was more prone to look towards guidelines before I developed my own views and experience. And so I think people young in their careers are more likely to rely on guidelines until they have experience and more clinical expertise. So you see younger people, or there's some people that think more for themselves and other people that are more don't, and they're more prone to follow guidelines. It's the way some people think. So there's different clinicians, doctors give different weight to different guidelines. Some may follow them more like a cookbook, and others read them and pick and choose what they think might be relevant, and others recognize certain biases that may exist. So there's a spectrum of how different doctors respond to different guidelines.
I think that both of you guys just pointed out exactly why, but it just doesn't make any sense that IDSA completely ignores the patient experience and the very obvious patient nature to go and lean towards ILADS doctors versus IDSA doctors. So you would think that they would just make the crossover occur. But Pat, it's very obvious that you pointed out one of those reasons as to why that's not occurring, which is potentially profit and insurers. I would ask that you expand on that a little bit.
Well, I think that's probably part of it. They have a vested interest. They are, when we did the investigation that then Attorney General Blumenthal did in Connecticut of the IDSA, he found a lot of undisclosed conflicts of interest with them working for the insurers, so to speak, and also with testing and with vaccines. So I'm sure that that's probably plays into some of this. And, you know, it's very problematic. And also, you know, they have been having this philosophy for many decades now. And of course, a lot of people ask, well, what would happen if their philosophy, their dogma, was suddenly found totally to be invalid? And I don't know that anybody has an answer to that. I don't know what kind of liabilities that might open them to, or, you know, what happens if that does occur. Now, many of us feel that there's already enough evidence to show that this already has occurred. There's a lot of literature that, you know, Bob pointed out that they just totally refuse to use. I mean, I saw this sitting down at the working group in Washington, what they tried to do to our patient section of the report and to chronic Lyme in general. They try to, you know, these are people that are sympathetic to this particular viewpoint, and they tried to have so many things removed. They would not even allow us to use, you know, chronic Lyme disease or persistent Lyme disease. And some of the literature, they wanted, even though the literature was in valid peer review from great institutions, they didn't want that to be there. And Bob mentioned earlier the animal study. studies. They wanted us not to use any of the animal studies, which showed, the fact that indeed there can be persistent disease after treatment. And it was amazing because it wasn't just a polite argument or a polite discussion. It got pretty heated, and fortunately, I and several people stuck to our guns, and we were able to keep, some of the things that we needed to have to help, bring this forward. But it's very problematic, and I don't think we know the full answer of what's behind this. But I'll say one more thing, and that is that early on in the disease, it was first recognized as a rheumatological disease, and the neurologic wasn't recognized till a bit later. And Bob may want to comment on that, I don't know. But what I'm getting to is the fact that early on, it was the rheumatologists who were doing, a lot of the work, and they were getting a lot of the research money, and they were doing a lot of the studies. They really had control of the disease. And so some of that may be recognized in, some of the things that are in these guidelines today.
Yeah, I'd like to add a couple points there. It's, if you look at it, I've dealt with this issue, not just with Lyme disease, but many other conditions. For instance, psychiatric illness and coverage or lack of coverage by insurance companies. And what you find is that insurance companies, pick the guidelines that are the most restrictive and are best for reducing short-term cost. They're not looking at long-term healthcare outcomes, but they're looking at short-term cost. They know that they're going to keep a patient in insurance company maybe 18 months. And so short-term cost containment is the bottom line. If ILADS came out tomorrow with a more restrictive guideline, they may very well follow ILADS guideline. And that's what I've seen with psychiatric guidelines in terms of treatment recommendations. So that's the role of insurance companies. Now, if you look at, let's say, the disparity of guidelines, there was an emphasis in these guidelines that treatment has great risk and little benefit. Now, if you look at the risk that they were basing it on, it wasn't really prospective controlled trials like they said you need. They really went to great lengths to try to find outcomes that were negative, and there really were very few that they could find from treatment. But if an example is doxycycline. They recommended either one dose of doxycycline or 10 days. Now, look at other guidelines such as acne. And acne guidelines that exist with different organizations, people are on doxycycline for years. And when they look at the risk-benefit equation, the risk is worth it when you compare it to the disease. Now, we're talking about the same drug, doxycycline. And when you look at the risk-benefit with Lyme disease, isn't the risk of inadequately treated Lyme greater than the risk of doxycycline, of giving it more than 10 days? But it seems like it's hard to reconcile that when we look at these competing guidelines. Also, there's guidelines from the American Psychiatric Association. The American Psychiatric Association recognizes that Lyme disease can cause psychiatric illness. And they recognize that that should be a consideration in your clinical assessment. And that guideline was not referenced in the IDSA guidelines. They did not make an effort to reconcile that. So it wasn't just ILADS. And it's, again, it gets back to risk benefit, and there's an imbalance in looking at how that is done, and it doesn't make sense from a scientific clinical medicine perspective.
Yeah, definitely. Without getting too off topic, I do want to mention to all those in the audience is that this insurance topic is going to be its own webinar because of how deep it goes. So keep an eye out. In spring 2021, we're planning to dig deeper into the issues posed to patients by insurance companies, but I do want to move on to back to the guidelines to speak specifically as to how these guidelines impact your average patient?
Well, the patients are often unable to be timely diagnosed or even correctly diagnosed with Lyme and other tick-borne diseases, and this can and does lead to chronic illness. Now, the My Lyme Data Patient Registry of 12,000 plus patients enrolled, 72% see 4+ physicians before diagnosis. 84% of Lyme patients were not diagnosed within the first 4 months of illness, and 36% were unable to get diagnosed before at least 6 years. So this is absolutely amazing to me, 6 years. And due to the lack of doctors willing to treat clinically, cost to patients and family for travel to doctor can be high. And My Lyme data said 31% of the patients had to travel 100 to 500 plus miles for treatment. And it's significant in particular for patients in much of the Midwest, the West Coast, and parts of the South, since the CDC surveillance criteria identifies states as being either high risk or low risk for Lyme disease. So now we have doctors who are already afraid to diagnose and treat. And so in those states, they're even more cautious because of that restrictor. So that leads to less available treating physicians, and those physicians are very reluctant and afraid to move forward. So people have to travel greater and greater distances. Now, also, the impact is seen in misdiagnosis of patients. And this makes the fact that patients might be taking unnecessary medications or medications with serious side effects, which may have caused permanent damage to the body, or medications maybe which even worsen their Lyme and tick-borne diseases, or cause more serious debilitating tick-borne disease symptoms due to the time lag before a correct diagnosis is made. My Lyme data showed 72% of patients were initially misdiagnosed. And some of the categories were psychiatric disorders, fibromyalgia, chronic fatigue, thyroid, rheumatoid arthritis, MS, lupus, learning disabilities, Parkinson's, ALS, etc. But of course, we know that the IDSA guidelines don't want some of those people to be checked for Lyme disease. Now, parents with children diagnosed and treated long-term by licensed physicians have been, in several states, brought up on charges of Munchausen by proxy. Now, what is that? That's when a caregiver either makes up or causes an illness or injury in a patient under his or her care. And so we have actually had state agencies take children away from their families just for them being treated long-term for Lyme disease. And this is, again, by licensed physicians. And sometimes this has happened in divorce cases where the Lyme diagnosis and treatment decisions have been used by one spouse, and it generally seems to be the husband, against the wife in custody issues. And there have been actual cases where the spouse has taken legal action against the treating physician in these circumstances. So doctors who do not treat using the IDSA guidelines are sometimes investigated by the state medical boards. They can be charged with malpractice, or if they can't get them with that, maybe they'll find some other charges to bring forth for them. And over the decades, treating doctors have lost their licenses. They've been fined, they've been monitored, or they've not been allowed to diagnose and treat, very specifically, Lyme disease. Hospitals have threatened their privileges. Insurers have threatened them from removal from plans if they treated long-term. And doctors who practice under the IDSA guidelines have reported other doctors treating with antibiotics long-term to medical boards and testified against them in insurance cases, as we mentioned before. Many of the treating physicians are no longer in any insurance plans, which is very sad. And some have spent hundreds of thousands of dollars to defend their right to treat patients long-term when they determine it's necessary.
So, Bob, I want to give you the option to respond to that question as well. And for those who didn't get a chance, it's the guidelines that not only affect patients individually, but these guidelines also affect clinicians and practitioners. So, Bob, how do you see that they affect those individuals?
Well, even though there's a disclaimer in the guidelines that it's individual judgment is needed, there's an effort to use these as a dictatorial approach of how one must treat Lyme disease. So that, and I've seen these cases, I've ended up involved with a number of these cases where I've been an expert in support of someone who's being faulted, be it the Munchausen by proxy cases, the doctors who are being faulted, and I think all these cases were won that I can recall, but it's difficult to go through. And what you often find, like for instance, Munchausen by proxy, it's impossible to do that Lyme could ever be Munchausen by proxy. Munchausen by proxy is contrived illness. How can you contrive Lyme? You may disagree, or someone may be hypochondriacal at worst, but you can't really contrive Lyme. That's impossible. There's certain illnesses that you can contrive. So we've seen less of these lately. I haven't seen many Munchausen by proxy allegations that have gone very far recently. There's some in Holland, but there's less of that. And the doctors being faulted, it can be very difficult. I've seen where doctors have responded by committing suicide from this. And I think what it is when you have a view that's opposing to a belief system, it can be very threatening to some people. And that's usually what happens, how these cases get started. That someone has a problem, they go to a doctor, and the doctor says, you don't have Lyme, there's nothing I can do to help you. And then they go to another doctor who gives a treatment and helps them. And then it can seem to be a threat. And then they want to report and go after the doctor in one way or another. And then it goes maybe through the system, and then the doctor eventually wins. But it's still an aggravation, and it's in some ways a power struggle. It's stressful to the doctor. They're just trying to help their patients. They're trying to do the best they can for their patients, but it is a threat to a belief system of the doctor who said, there's nothing I can do to help you. And then they're just kind of looking for something that might have gone wrong or could go wrong, and they're trying to jump on that to try to justify their prior position. So I'm generally seeing less of these cases than I used to see, because I think the tide has turned where the broader reaches of people are recognizing this is a real thing, and these doctors are trying to help their patient, and it's valid, and they're using their judgment, and they really are following the standard of care. And it is a treatment that's within the realm of medicine, but it's still, this battle is fought on many levels. In court cases, through child service, through divorce courts, through insurance company, what they call criterion. And I forgot to mention that before, that insurance coverage criteria is the phrase versus standard of care or versus guidelines. So it's all three of those are different things. And insurance company criteria is always the most constricted, because that's how they save the most money. So this battle plays out. It's always played out in science and medicine. It'll continue to play out. I've seen other controversies, and a lot of times in psychiatry, whenever there's a controversy in medicine, they get sent to psychiatrists. And then once it's resolved, then psychiatrists are no longer involved. You know, I look forward to the day that I'm not dealing with this controversy, but then I'll deal with some other controversy. And it is very frustrating. It's rather traumatic for my office manager to get all these calls that are constantly calling of begging and pleading to be seen. And there's only so many patients I, as an individual doctor, can see. And we had to close the waiting list because there were too many on our waiting list. And then we try to educate other doctors, and other doctors then learn, and then they quickly fill up, and then they can't see any more patients. There's such a demand for patients to be properly treated, and we have to expand the educational base. But it is very frustrating that we have this high level of technology in our healthcare system, but this access to something that's just very basic, based on clinical judgment, is impaired, is limited.
So thank you very much for sharing. And here's one thing that everybody wants to know, which is what happens next and how do we go from here? What changes can we make moving forward? So I'll pose this first to Pat, but what changes would you make to help the patient?
Well, first I want to say that when the science is unsettled, that's usually when there's more than one set of guidelines. And the National Academy of Medicine, which is formerly Institute of Medicine, IOM, indicates it's not possible to base all care on sound scientific evidence, certainly not on randomized trials, which narrowly define populations and exclude and control factors relevant in real-world care settings. And I think that's the operative word, in the real world. And these guidelines certainly don't address what's happening in the real world. So government agencies, CDC, NIH, military, insurance companies, hospitals, and medical schools need to acknowledge that the science surrounding Lyme is unsettled. And they need to accept the two standards of care for Lyme disease and educate physicians and the public about the existence of both on their websites, in education programs, and in literature. And we did get some things into the, I will say, the working group 2020 report to Congress, which right now is sitting in the hands of the Secretary of HHS. But again, it was a tremendous battle to even get some things that are so seemingly, things that you would ordinarily do for any disease, and yet to do them for this, it becomes a whole different ball of wax. So we also need a national Lyme disease curriculum to be developed with participation in a transparent process, but by all stakeholders. And the participation, including patients and long-term treating physicians, must occur at every level of the curriculum development, from the beginning through the end. Curriculum then needs to be promoted to the state governments after it's developed. And the federal government agencies to date have refused to agree to accept patient participation at all levels in the development of such curriculum, because we had that discussion again down at the working group, and they would not agree to that aspect. They agreed to patient participation, but not at every level of that development. There should also be a push to adopt the term chronic Lyme disease or persistent Lyme disease. And again, as I mentioned earlier, down at HHS, we weren't allowed to use those terms in our patient chapter. We had to use persistent symptoms associated with Lyme disease. There is a significant amount of literature from credible institutions, researchers, and peer review demonstrating Lyme spirochetes survive short-term treatment through several methods, including biofilm formation and also persister cell development, which is those persister cells are other stages of the Lyme bacteria, and they may require different antibiotics to kill them. Now, the research on that has been done by several prestigious institutions and researchers. And for this not to be accepted to me and not to be promulgated by the IDSA and also by the government is just a sign of a cover-up. That's all it is. So IDSA government agencies and some researchers have pushed back for decades against this idea of spirochete survival after short-term treatment. Yet no one of those individuals or groups has provided a gold standard test and one which can show active Lyme infection. And the bottom line is, none of those entities have provided any help or treatment for people with persisting symptoms, chronic Lyme disease.
Some of these things just seem so self-explanatory. It's bewildering that they have yet to occur, but obviously that's why Lyme Disease Association exists, Project Lyme exists, is to continue to push to make these changes. So aside from that, what are our options as organizations?
Can I make a comment first, Noah?
Yeah,
okay.
Go ahead.
Just so if you look at what's evolved in medicine, there's been a shift in medicine, the emphasis. Think of three players in medicine: patient, healthcare provider, doctor, and third parties. And there's been a shift towards more power with third parties. When I was in med school, one thing that stood out was the comment that you've had all these years that you'll have with your training and perfecting your judgment, and you owe it to every patient you see to use your best individualized judgment to help that patient. That's what you have to do with every patient. That isn't emphasized so much in training today. What's emphasized more now is that you have to look towards this other third party that gives directives of what you're allowed to do. So there's more of a dictatorial tendency. And you see it stronger in certain fields than other fields. I think it's somewhat more so in internal medicine super specialty fields. Less so in family medicine and psychiatry, nurse practitioners, less so in clinicians that are closer to the patient. So I think that's a shift of emphasis, and insurance companies, other third-party players try to take control of that physician-patient relationship, and we have to take it back.
Cool. So as organizations, how do we hit the ground running and actually respond, and what are our options to do so?
Well, first thing, and I was glad to hear you say about having a webinar on this, persuading insurers to accept long-term treatment into their plans by providing them with the statistics which show the cost differential between early diagnosed and appropriately treated Lyme and chronic Lyme. And interestingly enough, several years ago, I was invited to Harrisburg to speak before the insurance committee there, and I took a number of doctors and also other advocates. We went and we provided them, the insurers, they all sat around the table, and we provided them with very detailed statistical data showing these cost factors, what happens with people who are treated early, who are diagnosed early, treated early, and treated appropriately, and compared to the cost of people who don't have that ability to have that happen to them. So we presented actually for a couple of hours. And so what I always found interesting, if you will, after the fact, was that about, I'm going to say maybe a month after Pennsylvania was introducing a bill about Lyme disease and insurance to try to get the insurers to pay. And so what happened? I saw the response letters that were sent to the commission, the insurance commissioners there. And basically these letters were signed by the same representatives of the insurance companies that sat around the table, that listened and got all of this information from all the experts that we brought forth. And they were opposed to this legislation. And I said, you know, it doesn't make any sense. You're showing them in the long term that they are really, they're going to save people, first of all. And second of all, they're going to save a lot of money if people do not get to the point where they develop these chronic symptoms and require, these different skills and these different treatments. So it was amazing to me. But I remain somewhat optimistic. I have been contacted by a certain insurance company and had several discussions with them. And I don't know, maybe they're beginning to finally realize that, if you will, they're shooting themselves in the foot. I don't know. And I don't know what will come of any of it, but I believe that we still have to do it. We have to be, talking to them and trying to convince them that this is something that must be done for the health of people all across this country. Now, we also could seek actions in each state through state medical boards to recognize that two standards of care exist for Lyme disease. I know Minnesota has had agreements with the medical board there. In New Jersey, years ago, we did meet and brought in an expert to the medical board to talk about these issues, and that seemed to be helpful. We also need to seek state legislation protecting treating physicians. And now this has been accomplished in several states already. Rhode Island, Connecticut, Massachusetts, New Hampshire, New York, Maine, California, all have different types. I was involved with the first legislation that was passed in Rhode Island back around the turn of the century, and that was very exciting. There was a huge fight in the legislature, and I think some of the legislators were going to be, I don't know, their peers were not happy with them, but we did get it passed. So it can happen, but oftentimes what happens, it may become restricted. There may be restrictions, certain restrictions. The physicians may not be able to do everything, and there may be some things that are put on that legislation. And also legislation, again, requiring insurers to pay for long-term treatment. We did get that in Rhode Island at the same time. Illinois has passed it, and we did get a limited bill in Connecticut that has some limitations on that. We can seek federal legislation requiring the development of national Lyme disease guidelines, recognizing all stages of Lyme developed transparently by all stakeholders at all stages of the process. And we also can seek federal investigations, for example, from the GAO or other entities in government who are capable of doing investigations into what has been happening with Lyme disease and what is behind that. Now, there are also legal actions which can be taken, and currently, and I think a lot of people are aware of it, there's a civil suit by 23 patients that was filed in 2017 in Texas, and it was 4 counts under RICO and 1 count of violations of the Sherman Antitrust Act, and the defendants are the IDSA, 8 insurers, and there were named IDSA panelists. Now, to date, all of the insurers have settled, and I believe they have a tentative trial date for September 2021 for the other defendants. Now, basically, the IDSA, the insurance defendants, and the IDSA panelists, acting through their officers, agents, employees, and affiliates, committed numerous predicate acts of racketeering activity prior to and during the period made the basis of this suit, and continues to commit such predicate acts in furtherance of their scheme to prevent treatment of chronic Lyme disease and to prevent the proper testing of potential Lyme disease patients, including mail fraud and wire fraud. And that, by the way, is from the suit itself.
Thank you very much, Pat. So real quick, before we move on to this last question, I want to let everybody know, thank you very much for staying so long with us. We will get to the Q&A right after this. So if you can be just a little bit more patient, give us a little bit more of your time, we'll be able to answer your questions individually. So Pat, this last one is again for you and for everybody who is out here listening. What can the average person do in order to help out and push change in the right direction?
Okay, well, before I specifically answer, I want to say that my advocacy began because of what I saw in the mid-'80s in my school district, where I was a Board of Education member, where Lyme was striking down our staff and our students, and no one really knew what the disease was or provided help to the district. So without any support, I began advocating for students all over New Jersey who were treated terribly by the schools. And later, one of my children contracted Lyme, and then another Lyme and Babesia, which eventually led to, among other things, severe neurologic and cardiac issues and temporal lobe seizures. I presented the information about the severity of my children's disease in 1991, down to CDC and NIH, and about information about Lyme in our New Jersey schools with the help of my congressman. And I made a decision then that I would never let another mother go through this journey alone if I could help. And so my point being is, I was an average person. I was a mom of 3. And you know what? I'm still an average person. I'm a grandmother of 4. And they are my focus. And so everyone can do something, and no matter big or small, if they take an action, and everybody takes an action, this moves it forward. So you can educate your physicians about 2 standards of care. You can check with active organizations such as Lyme Disease Association and others who constantly monitor the situation, and they often ask for help with legislative or other campaigns to force changes in the Lyme disease diagnostic and treatment status quo. You can write, call, email, meet in person with your own legislators at the state and federal level and tell them of your experiences. And you can ask your friends and relatives with similar stories to do the same. But I want to say, and this to me is really important, and it's a caution to remember, that legislation should only be a last resort. Only think about it if all other efforts have failed, because once legislation is passed, it is seldom repealed. And this issue is a very complex medical and political issue, and legislation is often commandeered by the opposing side. And slight language changes, even 1 or 2 words, or moving a word around, can actually change the whole focus of the legislation, from it being beneficial to patients to it not being beneficial to patients. And people don't want to think this way, but legislators' interests may not always be the same as yours, and they may be persuaded to trust the experts. And we heard from Bob about who those experts claim to be, and those who try to suppress the seriousness of Lyme. So everyone can do something to help, and I hope that they will. And I thank everybody for this opportunity.
Maybe I can make a comment too in terms of how I got involved, somewhat different than Pat, where I, as a psychiatrist, a lot of Lyme patients are told, well, it's all in your head, go to a psychiatrist. And so and I've been treating a lot of treatment-resistant patients. So that was one source where patients would come to see me. But also a lot of the Lyme symptoms are psychiatric in nature. And so I kept seeing an increasing number of these patients in the past 30 years. And there was a very repetitive pattern. And there was no one else I could refer them to. And then I started to understand it. And because I couldn't refer them anywhere else, I had to figure it out myself. Although I spoke with Brian and there were other people, and then we have a group that we collaborated with, and now it's a group of 750 that we've organized, where we share information and help advance knowledge in this area. So it's, and I think in terms of back to the question of what, and I've testified like Pat has. I've been testified in Harrisburg a couple of times, and I understand what you're talking about. The insurance industry is very powerful in Pennsylvania. Each state is different. I've testified in other states and in Washington, and it's sometimes it's legislation, sometimes it's legal issues, sometimes it's media, sometimes education, whatever works. But each of you, and there's this army of mothers, and it's like the image of don't ever stand between a mother bear and their cubs. It's a very dangerous thing for someone to do. And when you have this army of mothers who are protecting their children, and they see their children harmed by this disease, and they see the medical, part of the medical establishment impeding treatment, that's not a smart thing to do. And this army of mothers mobilizes, and often that's who drives a lot of these organizations. I've worked with a lot of different diseases, but I've never seen so many advocacy and support organizations as I do with Lyme disease. But I think that's needed. And now each of you might be able to contribute in your own unique way. And when I look at advocacy with Lyme, I've seen some very creative things that people have done. So I'd encourage each of you to come up with some idea of how you can advocate and how you can make an impact. And Pat's way has been different than mine. We've done different things. Sometimes we do a joint effort, but everybody can come up with some idea and think about it. Think of how you can have an impact.
Thank you so much to the both of you. Again, I want to reinforce that Project Lyme is happy to be able to provide these events for free. I will put the donate link in the chat one more time, just in case anybody is interested in donating and helping us continue to provide webinars like these through 2021. And also thank you everybody for sticking with us again and putting such great questions in here. I'll go ahead and get started with the first, which is, how does the Federal Tick-Borne Working Disease Group and its findings intersect with the approach that IDSA takes to creating the guidelines?
Well, I think they totally intersect. And I think that there are, my opinion is, I believe there are certainly discussions that are held. And I felt in this past working group that I just, finished up with, I felt it was very evident. When we had the first working group, we had much more congeniality and agreement on things that could be put in there to help patients. On this group, we didn't have that. And I felt that there was a pushback. And I felt that after reading the IDSA guidelines, after having finished the working group report just within the last 2 weeks, I said, wow, these things all dovetail, and the arguments that were being used down at the working group were the same arguments that are used with the IDSA guideline. Not every one, but a good % of them. And I felt like that there certainly was an interaction. Now, don't get me wrong, the working group has rightfully been put together that it contains people with different viewpoints. So that's certainly understandable, and I get that. However, the working group was also meant to be pretty balanced, and to have one patient representative, which was me, basically. This year, the last 2 years was really, to me, saying to patients, we don't really care what your viewpoints are. And so instead, they put other people into 2 of the slots that last time around they had 3 patient representatives. And so do I say this dovetails with what the IDSA is doing? I totally feel there's a relationship. And I think that many of the things that the government agencies have done over time have shown that relationship. Their reluctance to they would not put up ILADS guidelines ever on the CDC website or NIH or any of the other agencies. And even though we requested it, we asked, we had meetings about it, and they always said, well, the IDSA, we feel that the IDSA has the best information and the most, scientific information. Well, I'm sorry, but yes, it could be the most scientific information when you neglect 50% or more of the literature that's out there to support the other side of the equation. And of course, that's what was done. And it's the same thing, if I may, and maybe I'm branching out, but it's about the working group, the government agencies, and all of this. But for example, with the NIH, for years, our researchers who supported having an open mind when they did their research to look at answers to whether or not there was chronic persistent disease. And they would put in these research projects, and they most often would not get funded. And then we found out basically the bottom line seemed to be that these peer-reviewed panels that the NIH had, those entities did not want to look at anything to do with chronic Lyme. So either the thing was deep six before it got there, or yes, it was looked at by the peer-reviewed panel, but oftentimes the people that sat on that panel had this dogma and this biased viewpoint. And so very few of the research projects that could have been funded were funded through the NIH. And so to me, this, it's kind of an unholy alliance between these entities that are all what some people call Lyme denialists. And so it was very problematic. But I do want to go back and say, I feel that the working group is a good thing. It's brought out a lot of things, but that we have to ensure and provide oversight as a Lyme community onto this body so that the next 2-year term that they do the things that they're supposed to do, and that they have the diversity of viewpoints, and they aren't necessarily controlled by entities who have this particular dogma.
I think a common thread you see here with government agencies is what we call back channel communication. So that even though on the surface there's something like when you spoke about testifying in Harrisburg, some lobbyist behind the scene then had some back channel discussion and flipped around the opinion. And it's always invariably covert. It's hard to know who's saying what, who's pulling the strings. But that's often how business is done with governmental policy setting. We're not used to that in medicine. Well, it's a part of medical politics, but it certainly goes against what science is supposed to be, where it's factual and open. But that's what we're up against. And it's hard to know who's doing that back channel communication, how they're doing it, and how they're getting to people and at what levels.
Right. And I just wanted to say also that, it would be different with something like a working group or whatever, if we started out with a level playing field, meaning that both sides had, equal voice out in, out in the social media, out in the literature, and so on. But there hasn't been equal voice for the 36 years that I have been involved with. I haven't seen anything equal about it. Because again, the side that says, well, maybe there really is chronic infection. We have a lot of literature that's showing that. We have animal studies, and in some cases, perhaps some human studies that are indicating that, but yet those studies and things are ignored. So there's not a level playing field to start with. So when they then take away some of like our advocates or people that are knowledgeable. Like there was no ILADS physician on the working group this past year. And so that was very problematic. However, there was an IDSA representative on the working group. And so we have to be very vigilant as a community, and we can't let them do these things. And the only way you can't let them do it is you have to be vocal. Sometimes, unfortunately, people feel they have to be nice and they have to pat other people on the back. Well, I'm here to tell you, after 40 years of experience in politics, that doesn't always work. That's nice, and there's certain places for that. But when you get down to the bottom line, and when your patients are being deprived not only of treatment, they're being deprived of their humanity. They're being told, sitting at the working group by these people, that, well, we don't even know that you have Lyme. Well, what about the fact your doctor diagnosed it? Well, what did they diagnose it with? And yet they claim the tests are good and everything else. And so we have to learn, we have to be stern, and we can't let them get away with things. And we have actions we can take, we should take, and people are beginning to take.
Thank you very much. So I want to make a quick statement. I'm getting a lot of questions, and as you see, one question can lead to a bunch of different discussion, and I don't want to hold anybody too long. So what I'm going to try to do is get to as many people as I can, try to combine some questions together, especially those that overlap. So if I don't get to your question specifically, I'm sorry. Hopefully you can either reach out to myself, you should have my email address, or Pat, or somebody, and we can continue this discussion offline. But I will go ahead and lead back into this. Is obviously there's been a lot of discussion of ILADS and how much patients prefer their treatment guidelines and their standards of care over IDSA. So how do we move ILADS into the premier space? Obviously it's already in the premier space, but how do we make it nationally recognized and easily accessible to individuals? And outside of that, how can we better use marketing either through social media or other locations to try to spread ILADS and their more favorable guidelines as far as we possibly can?
Well, we've tried a number of approaches with ILADS over the years. And even though it's true that ILADS is smaller than IDSA, but if you actually think about it, probably ILADS doctors, ILADS members treat more Lyme patients than all the membership of the IDSA.
Yeah.
Because most of the membership of IDSA never treat Lyme disease. If you look back, there was a Senate hearing a while ago about COVID, and there were doctors who were the frontline doctors, and they were saying, do these repurposed drugs that are not FDA approved for treating COVID, but they're effective and they save lives. And then they had another doctor say, these are unproven treatments, dangerous, and they should never be used. And he was the doctor from the IDSA. And the senator asked him, doctor, how many COVID patients have you treated? And he said, none. Whereas the other doctors that were testifying deal with these people day after day. So I think you're looking at who do you pay attention to, the doctors who are in the trenches or the doctors who are in a distant location but are connected, politically or with funding and try to take control of a disease. If, let's say, a psychiatrist were called into the epidemic in Lyme, Connecticut to do the initial evaluation instead of a rheumatologist, I think would be in a very different position today. And as it turned out, it's once a certain group gets control of a disease and the funding for disease, then they want to keep control. And, you know, we try with different approaches to educate. And what we're doing is trying to educate doctors. And we have this education program that we developed over a period of years. And so that's the day before an ILADS meeting, and that helped. And we have things for the public, and we're doing a lot of things. We try different things, some pan out, some don't. But we are trying to expand the base, but it's certainly good for other people to recognize it. And, you know, and people try to fault ILADS who have opposing beliefs. So we're always dealing with that. But I think we've made progress. We have our yearly meetings. We have our meetings in Europe, and we've expanded. We truly are international, not just a name. And I was present when we had the first international meeting, and then we developed that. It was in London, and then after that we had in Germany, and now we couldn't do it this past year because the COVID. So, but we do have an international presence that's expanding and going. We want to go to, you know, different continents. So we're working at it, but public support would help.
Yeah, I'll just add one thing, and it may not seem related, but I believe it is. I think that also patients need to, if they feel comfortable enough, you know, sign up for example, my Lyme data registry, and put their information in there. And the reason this is so important is because, you know, they've tried hard to keep the actual information about what is happening to our patients out of the literature as much as possible. But a registry enables that information to be put to good use. And so we can say that so many people, you know, now use doctors who support you know, the ILADS guidelines as opposed to the IDSA guidelines, things like that in questions that are used and so on and so forth. So I think that the Lyme data registry seems to be a very top-notch patient registry. And if people, again, are comfortable, I think that they should think about whether they want to, you know, answer questions so that their information can be part of this database that can be used to show these are the problems that are really happening to patients. And no, they're not being addressed, which is why patients have to travel 500 miles, you know, to get treatment for Lyme disease. I mean, when you're talking between 300 and 400,000 cases a year in this country alone, it seems obscene that people would have to travel those distances to get a doctor just to treat them.
So I think this is a perfect follow-up question. How do we shift the influence from those who don't necessarily live and treat to put those who live and treat with tick-borne diseases into a position of power, into a position of influence, either within the federal government or to be able to make changes that will positively benefit Lyme patients?
Well, I would like to say, it's my opinion, we've already done that to some degree. I mean, I can tell you again, when I started back in 1984, I remember, well, there was nobody. And so, you know, and we had to kind of scuttle around to find information and find people that even knew what Lyme disease was. And so we've come a long way from that. We've been informing Congress. We've been getting bills passed. We've been getting policy changes made. And also what I think the patient community has to be careful of is when they're asking for money, when they're asking Congress to appropriate money for Lyme disease, they need to ensure that they are very specific. They have specific language as to how that money is to be used. Because if you just appropriate, let's say $50 million for Lyme disease to the government, that doesn't necessarily mean that our 20 or more % of chronic Lyme patients are going to see any benefit from that. And so people have to start thinking in terms of not just getting in positions where they can influence policy and legislation, but to making sure that that policy and legislation is going to influence chronic Lyme disease. And that's not to demean anybody who's ever had Lyme disease in general, but it's because we don't have an emphasis. We don't have the money there. We don't have the answers there. And so I think that we are making progress. And again, everyone can be influential with their own legislators all the time. If you see them in the grocery store, which some people do, if you know their family or you have a relative that knows them, I'm sorry, but go ahead and use that influence. Get your story out there. You have to tell them. And the bottom line story is, I am a patient who was very ill, or my family member, and I cannot get treatment. There are people today that still don't know that you can't get treatment when you have chronic Lyme disease. And so they have to put it out. And that is why the numbers are building, because the numbers, unfortunately, of patients are building. Social media is helping that, getting that message out. I think that, those are the ways that you do this. And you can, an organization has to be careful about doing this, but individuals can certainly, if someone is running for office, they, at any level of government, no matter what it is, they can say to that person, I would like you to put into your platform something about chronic Lyme disease and what you're going to do about it. And that is a way that can be influenced.
One thing that you have to look at with policy setting is the concept of follow the money. And if you think about that, that often is the issue. In psychiatry many years ago, there was very little money in psychiatry. And what happened was that there was little interest in people wanting to get involved. And then drugs came along, or hospital chains existed. And then there was a discovery that you could make money either by providing something or by obstructing something. And I see that with Lyme. Now, where's the money in Lyme disease? Now, so what motivates is a treatment, a test, something, or a vaccine, something that people might be able to make money from, or obstructing access. But in reality, the money involved with Lyme is the cost of disability to a large number of people and the lost productivity. But that's not something that someone can make money from. That's something that people lose money from. If people could understand the catastrophic loss that occurs from the inadequate diagnosis and treatment of Lyme disease, that might be something that would mobilize people. But that's kind of a societal issue. It's not something that motivates an individual thing. When we tried to recognize depression in psychiatry, nobody cared. But then once drug companies could make money with antidepressant medications, then they had a PR campaign that took off and really had a lot of momentum. And only then did people recognize, well, depression's significant, we have to treat it. So sometimes you can team up with someone who has a commercial interest where it's mutually beneficial. But up to now, it's been hard for that to exist with Lyme disease. There's been money in research grants. So people look for the money in the research grants, and then a lot of this research money gets wasted accomplishing nothing. So it's what motivates people. We have to look at that and try to appeal to that.
So this is going to be the last question for the night, and I think it's a good one to end on. For those who obviously are attending webinars like this to learn more about Lyme disease, about things related to the community and the legislative aspects and the advocacy aspects, is there a best source of core education for people who want to learn more about Lyme disease aside from attending these webinars? Obviously, there's a lot of literature that's out there, and is there something that might be more streamlined to help an individual get up to speed with what's really happening in the Lyme community?
Well, are you, let me ask a question. Does it say, when you say up to speed, are you talking about up to speed on actions, or are you talking about up to speed on the disease? I'm unclear. Is there a distinction there, or?
I think it would be a little bit of both.
Well, then I have to say, I don't know that there's really one source.
Yeah.
I think you have to look to, there's a number of groups out there, and a lot of the groups specialize or whatever in certain areas, you know, of what they do. You know, or some are a little broader. And so you can find what groups do what and take a look at what, you know, what they recommend that you do or what they have done and what can you do. And you know, I don't know that there's one source that you can really go, not that I've seen, let's put it that way. And you know, I would say, like, for example, we fund research, education grants, you know, we do, you know, stuff with legislation, obviously. We have a Lyme Made for Kids program, blah, blah, blah. You know, we have a lot of data. A lot of the other organizations have one of those things, or perhaps more than one, or other things. So you need to take a look around. And I don't see that there's not a book or a manual. It's something that everybody has areas of expertise. So you want to try to find those areas of expertise by looking at what they do and then read up on them. Unless, I don't know that Bob has something more comprehensive than that, but that's the thing I would say. And obviously, one other thing, if you're looking at the disease itself, then in my opinion, you need to know, even if you don't want to, if you want to become an advocate, you need to know both sides of it. Don't just learn, okay, here's the ILADS guidelines, here's what they do. Yes, I think you should know approximately what they do and, you know, what's behind them. But you're also going to have to learn about the IDSA guidelines and you know, the other side of the equation. You're going to have to learn about what the CDC and the NIH, what is their positions. And so in order, the only way to do that is do a heck of a lot of research and reading on what these entities do and what their positions are. And then that way you'll be able to go out there and take, you know, do different things. I mean, the level of knowledge that's required is different. You can do things with a, you know, a beginning entrance level of knowledge, and you can do things with a level that's much higher. It's up to the amount of time, energy, and health that you have to devote to these things, and you have to make that decision as to how much, you know, that you have, and then pick and choose the information you want to study.
Yeah, something to add. I did give half a dozen references, and one was there's a website on Lyme disease guidelines. Another was my journal article I did critiquing the IDSA guidelines when it was the proposal, which is basically the same guideline that we see today. And a couple of the journal articles that were relevant today to this discussion. And I'm not sure where you want to post that, but the Lyme COVID Facebook group has covered some of these things. It doesn't just cover Lyme and versus COVID, but it's touched on that. And yeah, there's many different sources depending on the level. You're looking at the legal issues, the advocacy issues. Are you looking for scientific information? Are you a professional and you want to connect with other colleagues and learn from other colleagues? There's a big gamut of sources. The number of journal articles on Lyme disease is amazing. You know, I used to track it and count it, but it gets out of hand. It's probably around at least 30,000 or so, and a lot of those conflict with each other. So there's an information overload when you go looking for information on this.
And if I just, in closing, could just also say to people who are interested in becoming advocates and doing something, you can't let yourself get discouraged. What you have to do is focus small to start with if you're thinking of becoming an advocate. Focus maybe in your community to start with, get those people together, you know, then you'll have a few people who will form a group with you if you need to, and then move on. Because what the biggest thing I see is people come in and they think they can come in and change things overnight. And that is, unfortunately, believe me, I have, among many people, would like to have seen that happen many, many years ago. It isn't going to happen. So you have to pick your little corner, your little thing that you can, I say little because you're going to start out little, hopefully, and then work up from that and build from that. And then you will have an impact, even if you're an impact at the local level to start with. You'll have an impact. You know, get your town legislators to have a town meeting on Lyme disease. You know, go to them and stand up and talk about it. This is how you start. And then you can move from there. And then other people say, oh, I wanted to do that. And they come to you. And then you get together. And then you become a group, and then you get maybe larger. And so, but I think that too many people take off, you know, take more than they can do, and then they may be sick and they get discouraged. And then, you know, they think, well, I can't do anything. And that's wrong. I know these patients. They have an amazing, amazing inner strength. And they can do this. You can do it. All of you patients out there, I know you can. And I will say, I had a daughter that was in temporal lobe seizures for 3 years straight, for 6 out of 7 days a week, for 15 to 18 hours a day. In these seizure states, she didn't even know who she was half the time, where she was. And this is a child that went on to graduate Phi Beta Kappa from Johns Hopkins. So these things can be done. You can overcome your disease, and you can do things to help. But you have to remember your own limitations and put your health first.
Thank you very much, Pat. And thank you also, Bob. In closing, I just want to state that I put my email address in the Zoom webinar chat. If anybody wants to get more involved, either directly with Project Lyme or with just Lyme disease advocacy, education, and the nonprofit space in general, feel free to reach out. Additionally, I want to give a short shout out to our Generation Lyme initiative. It is a very similar to this, but in a lot less, it's actually more of a Zoom call instead of a Zoom webinar, and it provides support and a support system and a community to any of those either currently suffering with Lyme or who may be in remission and just are still looking for a community who understands what they have gone through. So if anybody wants additional information about that, again, you can reach out, or you can find them on Instagram at Generation Lyme. So there's a lot of things that are currently happening. We really want to continue to support the community, continue to provide opportunities for people to be involved, and continue to push for progress. So again, thank you so much, Pat. Thank you so much, Robert. And thank you so much to everybody who has joined this webinar and sat through and taken in all this spectacular information. And I look forward to having all of you back the next time that Project Lyme is hosting a webinar. I know it's a little bit premature, but we do have one planned on January 21st to discuss the intersection of Lyme and COVID. Dr. Rawls and Dr. Daniel Cameron will be joining me and participating in that the same way that Pat and Robert have today. So again, thank you very much. And I'm going to give Pat and Robert one more second to say their goodbyes, and then I'll be ending the webinar.
Well, I want to say thank you to Project Lyme. We appreciate this opportunity to educate. Thank you very much to everybody there. And I thank everyone who took the time to listen today. And together, we can do it.
Yeah, thanks everyone for taking the time, and thanks for sponsoring. And I agree. We can really make a big difference. And I think what we're dealing with is a quote by Max Planck that science advances one funeral at a time. And I believe what happens is people get a belief system, and once they have it, they're locked in because that's what they've always thought, and it's hard for them to change. And when new people come along and look at it differently, there's a resistance to it. And by people that are entrenched in the old belief system. But take good care of yourself so you can advocate longer than people who oppose it, who are locked in to an outdated belief system that just isn't valid. And I think it's a matter of time till people can understand this. It's a complicated disease. It's not easy to figure out. All the easy to figure out diseases have already been figured out. The complexity of this is the big issue. And people that try to take a simple model for a complex disease are trying to fit patients in the box that they don't belong in. So we have to listen carefully to the patients, and we have to learn from that and progress based on that. And I think we're headed this way. I see the way this movement to understand and appreciate and recognize and deal with Lyme disease more effectively, how it's grown over years. When we created ILADS, there were a handful of us. And the number of people treating this was just a small number. And when I look at how it's expanded and it keeps expanding, I see that we have the momentum in the right direction. So let's continue it.
All right. Thank you so much, everybody, and good night.
Night.
Night.